We do. Good morning and welcome to the January 15th meeting of the Joint Standing Committee on Health and Human Services. We have on our agenda today for this morning work sessions on LD 1583 and LD 555. I think we'll get started by allowing the committee to introduce themselves. And we'll start to my right with Representative Graham.
Thank you, Madam Chair. Good morning, everyone. My name is Representative Annie Graham. I serve the people of North Yarmouth and the majority of Gray, House District 105. And it's kind of miserable out today, but we'll be happy otherwise.
Good morning. I'm Representative Lucian Daigle. I represent House District 1, way up north. And hopefully it's not gray, but white up there because we still want more snow.
Hello, good morning. Representative Flavia De Brito. I represent House District 64, which is part of Waterville and part of Winslow.
Good morning. I'm I'm Marianne Moore, and I represent Senate District 6, which is all of Washington County, along with 16 communities in eastern Hancock County. And I need to be cloned today because I'm in marine resources at the same time. So
Let us know when you figure out the cloning thing.
when I find the cloning machine, we'd love to clone you.
Hi, I'm Michael Lemlin. I represent House District 53, Chelsea, Randolph, Pittston, and Dresden.
Hi, I'm Representative Dan Shigori. I represent House District 55, the communities of Hollowell, Manchester, and West Gardner.
Good morning. My name is Julie McCabe. I represent District 93, part of Lewiston.
We're joined by Representative Griffin on Zoom. Hi, Abby.
Hi, thank you. My name is Abigail Griffin. I represent House District 34, which is Glenburn, Levan, and Keduskeag.
And I'm Representative Michelle Meyer, serving Southern Maine's District 150, which is all of Elliott and parts of Kittery and South Berwick. We are also joined by our nonpartisan staff today, Anna Broom, up at the desk, and our clerk, Sophie Dubé. We'll get started with LD 1583.
Okay, so LD 1583 was a bill that you heard last year and also had a work session on last year, and it was carried over to allow parties to work on an agreement. And I'm going to go through the amendment that you have, what it does. The whys you can ask different people. So this is an amendment from Representative McCabe. This bill was sponsored by somebody who's no longer in the legislature. So so they had to find a new, so I guess Representative McCabe is picking up the slack. It was originally sponsored by Representative Cloutier. So let me just tell you what the amendment does. So this bill, if you remember the problem was the issue of a person who had a doctor out of state who was living in Maine and needed home health services. So it was originally drafted to include hospice, and that has been removed from the bill. And if you want to know the why for that, that's a Lisa question. So I'm just going to let you know what the rest of the amendment does. It's broken up into a couple of parts. So the requirements of the home health care provider. So the home health care provider needs to be licensed by definition and also certified by CMS to participate in the Medicare home health program. So that's a requirement of the home health care provider in this particular circumstance. The order can only be up to 90 days, and my understanding is that's not a renewable thing. And then the physician who issued the order, so this is the out-of-state physician, needs to hold a license in good standing from whatever that appropriate medical board is in their state that they normally practice in. And the home health care provider must verify that the physician's license is in good standing and maintain that verification on record so that it is available for review by the department. The physician that issues the order has to be issuing that order in pursuant to an in-person exam. And the order is limited to the the services, I'm sorry, are limited to the medical purpose and clinical scope resulting from that in-person physical exam. And the compliance with standards allowing the physician to license in another state must be in accordance with the rules by the department and CMS. The exemption from the medical license, so now we're turning to the person who provides the order. So that person, we've already mentioned, has to be licensed in another state, but they are exempt from licensure by the Board of Licensure, which is the MDs, or the osteopathic board, which is the DOs, solely for the purpose of this particular thing. Again, the order is for no longer than 90 days. The physician is allowed to provide telehealth services to that person, and only that person. The physician, this is again a repeat that the order comes, the services only come from a home health care provider that is licensed and certified. And the physician may only order services while the patient is receiving home health care services. So in other words, if that patient ends up in the hospital, then there's a different, that doctor can no longer order services for that patient. And the last sentence is really just the belt and suspenders. I'm not sure it's necessarily necessary, but if the stakeholders feel better having this language in that says that a physician acting under this section is not authorized to provide telehealth services or in-person medical services to any patient except as outlined in what we just went through. And if there's a violation, in other words, if there is a determination that a physician or the home health provider is providing services to a person where that physician is found in violation of this section, I'm not going to come up with the scenarios, but say there is a violation and that comes up during the process of licensing by the department or, CMS examination or whatever, then the department, in consultation with the Board of Licensure or the Board of Osteopathic Licensure, will determine if that physician loses their exemption. So it's not a financial or whatever. It's just like, you can no longer do this. Your exemption is gone. And then just the rulemaking language, and the rulemaking language in this section of law is all over the place. And so it would have been nice to have had some rulemaking language for the entire section, but there's background checks in there, which is different rules. So just to be sure, since there were reference to rules already, we just made sure that it was in that section. So that's what the amendment does. Any issues about the sort of policy questions? It's not me. I'm just the scribe. And try to make sure that it works. That's my job.
Question?
Can we have,
Lisa? Yes, we would invite Lisa Harvey McPherson up, who's worked diligently with all of the stakeholders to come back with amended language.
Thank you. Good morning. Lisa Harvey McPherson. I'm the Vice President of Northern Light Health for Government Relations, and I chair the Government Affairs Committee for the Home Care and Hospice Alliance of Maine. So I led the work to negotiate this amendment with my colleagues from Andwell Home Care and Hospice in Lewiston, along with their medical director, Bill Monteo, and Tim Terranova from the Board of Medicine. And I have to extend a deep appreciation for Bill Monteo and Tim Terranova. They were outstanding partners in all of us getting to yes, and I thank them.
Go ahead.
so my question then, Lisa, would be is why was
Yep.
hospice services removed from the bill?
So in approaching this, it was very important to the Board of Medicine, who understood the most acute problem. There's a patient in, for example, in a hospital in Boston and needs to come home with home care services. And without something like this, that patient can't access care. As we began to talk about home care and hospice, hospice has a medical director on the interdisciplinary team, and that medical director would have a Maine license to practice medicine. So there are different options for hospice patients because of that interdisciplinary team medical director than there are for home care patients. It's not ideal, But what we envision is a patient could come home with home care services, have the acute service structure established. Very often, they probably would be on a palliative care team. And this 90 days would give us time to transition over to the hospice, work with that hospice medical director. So their care needs would be met. They would just have a different pathway. And as I said, there was a rigor to the discussion to have a very strong framework that this is a very limited exclusion to Maine's licensing requirements. And the board and Tim wanted to be very intentional to have a structure that was so limited, it could not be subject to fraud, and it would not be subject to kind of the woodwork effect that everyone, all these doctors in all these states now want to come to, want to do this in Maine. So we could see an opportunity that hospice had a different path to meet the patient's needs.
I understand where that's coming. Well, I'm disappointed, but I
Mhm.
understand that.
Yep.
But I support the work that's done.
Yep.
This is great work, and I really appreciate that. And I remind members of the committee, there's a lot of people that live right on the border of the New Hampshire,
Yep.
in the Elliott area, and
Yep.
their doctors are actually in New
Yep.
Hampshire.
Yep.
And, and so they're dealing with the medical and
Yep.
that's the specialties,
Yep.
so
Yep.
this is really important,
Yep.
because they may reside in Elliott, but they're doctors in New Hampshire, so they need that
Yeah.
home care.
Yep.
And I want to thank you for speaking on behalf of my constituents.
Yeah. So the border issue is interesting because we have a 90-day limitation, and there are laws, a number of states, probably 10 or so, have laws around this issue. And Illinois' law limits it to 90 days. And for the first kind of trial of this, that was an added level of kind of security to the framework that the board was interested in making this a very narrow exemption. So for the border patients, if their doctor is across the border and they need home care services, and I'll talk about why we talked about the certified home health agency in a minute, we would envision that their services are probably more acute in nature. Let's say it's a post-operative wound or diabetes care or something like that. And they can have home care for a period of 90 days. And that really will take care of the most acute phase of their home care service. When they move into kind of chronic level of care, they need home and community-based services for a longer period of time. This doesn't solve that. And I think, and the board does, Tim did tell me they do get calls about border patients. So I think we'll learn from this, and then we may have opportunities with future legislatures to come back and say, here's what we learned, and we want to amend it in this way or that.
Allow it to be renewed.
Yep. Yep. Oh. Yeah.
What were you gonna, go ahead, Lisa, what were you gonna say?
Oh, I was gonna say, probably a question you have in your mind is, what's the role of a Medicare certified home health agency versus every licensed home health agency in the state? There are tiers of kind of intensity and acuity of services in home health. And the Medicare certified home health agency is structured around that intense, high acuity, post-acute patient, needs intensive nursing, needs therapy, PT and OT, may need some social work to help with family dynamics. So it's really kind of an extension of that acute care service. Licensed home health agencies have a complement of those services, but the intensity of the care tends to be at that top tier. So the agencies certified by Medicare have a different regulatory rigor. And so they're better structured to have stronger oversight. So.
Thank you, Madam Chair. Good morning.
Good morning.
So to that point, so the 90-day piece it makes an enormous amount of sense. And then therefore, their physician at home would then take over if they need continued care, correct?
Yeah, what we envision, and I'm glad Representative Zager is here, is, the kind of the scenario we talked a lot about is the patients in Boston, had complex surgery, has complex surgical orders, post-acute for the home care nurses and the therapists to administer. The general practice surgeon, doc isn't going to write those orders.
Right.
But after a 90-day period, that patient has transitioned from that acute kind of post-hospital intense phase of their care to kind of more stability, and the predictability of their care post 90 days is one that would be of more comfort for the family doctor to take care of.
And the question I actually have is, the removing the requirement, that they must contact the primary care provider in the state. It's a requirement. I mean, I would want to know if my patient came back from Boston and was receiving care. Can you tell me a little more about why that was removed?
So the burden of that was on the referring physician.
I see.
And so we wanted to shift that burden in some ways to the home health agency that's working with the patients in the community. And we would, the patients come back, they're going to be having, follow-up care, not only with their specialist, but with their family doc. And we saw the home health agency having a bigger role there than a surgeon in Boston.
Thank you.
Any other questions from the committee for Lisa or our analyst? Seeing none, I would entertain a motion. Yes.
I make a motion that we ought not to pass, excuse me. No, I'm kidding.
Get your thoughts together there.
My brain's in the marine resource though. No, I make a motion of ought to pass as amended on LD 1583.
We have a motion ought to pass as amended. Do I have a
Sorry, Lisa.
second? Motion and a second from Representative Graham. All in favor? And we've got Representative Griffin as well.
Thank you.
Thank you.
Thank you.
Moving on to LD 555. Oh, of course, yes. Representative Zager has joined us.
Thank you, Madam Chair and Senator. I am Sam Zager. I'm honored to represent District 116, part of Portland. Please forgive my tardiness.
You're forgiven. We're glad you're here. From your doctor.
That's true. I like that.
All right, LD 555. This is an act to create a separate Department of Child and Family Services, and you have a fairly significant sized packet in front of you. And if you looked at your email last night, you also had many more things that you could have looked at. But I try not to keep all of the foresters in business, so I didn't want to print it all. So first of all, what the bill does. And I'm going to spend a little time on this because it is a long bill, and the bill that you have in your folder has a short summary that doesn't really describe sufficiently what it does. So in Part A of the bill, it enacts a new Title 22B. If you remember or happen to know, 22A is a also very short chapter that is the structure of DHHS. Most of the things that you do in here are in Title 22, but there is also Title 22A, which is the very short chapter, and this would create another short chapter, title, I should say, that creates Child and Family Services. So it creates a new department and transfers the functions of DHHS that relate to Child and Family Services and to child welfare to the new department. With available funds, I'm going to just say DCFS, so I don't have to keep saying Child and Family Services, shall provide services for child welfare, Head Start and childcare, maternal and child health services, including home visiting, residential and long-term care services for children with disabilities, children with special health care needs, children with developmental disabilities, and transition services from child to adult services. The new department would have a commissioner appointed by the governor and confirmed by the legislature, as the current commissioner of the DHHS is. So that's the same process. And the commissioner may appoint all deputy commissioners and office directors in the same way that DHHS does now. The Commissioner shall establish procedures for hearing grievances of children who receive behavioural health services with opportunities for hearings before a state hearing examiner or an independent hearing examiner. And the Commissioner shall approve all programs for behavioural health services to children's residential care facilities and participate in licensure. And twice a year, the Commissioner shall submit a report to the HHS Committee with an overview of unmet needs of children and barriers to providing services to those children. So Part B is the transferring unallocated language part of the bill. It establishes the provisions for transferring the functions to the new department. All references, responsibilities, and authorities that are conferred upon DHHS that relate to child and family services and child welfare are deemed to refer to the new DCFS as created in the bill. Rules, contracts, agreements, and compacts of DHHS that pertain to child and family services would remain in effect, and records must be transferred and employees retain their rights, privileges, and benefits. The Commissioner shall submit a report with recommendations and legislation to the Governor and to the HHS Committee regarding the establishment and implementation of DCFS. Any conflicts between Title 22, 22A and 22B, the new one, or rules adopted under those titles, the Commissioner shall attempt to resolve the conflict or inconsistency by interpreting the laws or rules, and the Commissioner may submit legislation and has sole discretion to determine if a rule should be deemed an emergency rule. The Commissioner of DCFS shall work with the committee, with OPLA and the Revisor's Office to review the statute to correct inconsistencies and errors. And the Commissioner and the committee shall agree on the format and organization of Title 22B, and legislation must be submitted. The committee is authorized to meet as needed, but at least 3 times during the interim to carry out the responsibilities of planning, service delivery, and implementation issues in relation to establishing the new department. And the committee may is authorized to submit legislation. The Department of Administrative and Financial Services, the Bureau of the Budget, shall work with DHHS employees to transfer duties to DCFS and develop a budget for the department. And if the Commissioner of DCFS determines that federal approval will not be obtained for any part of the Act that requires federal approval, the Commissioner shall notify HHS Committee and the AFA Committee and the Legislative Council. I'm not going to spend very much time on the testimony, but you did hear concerns around on sort of both sides of this around whether a new department would create silos between departments versus consolidating all youth-related programs and offices within a new department. A separate department would have a cabinet-level commissioner. You heard testimony again, sort of on both sides about children not being removed from families when they were unsafe and then coming to harm. And you also heard testimony from family members who feel that their children were removed when they did not need to be. And then you heard some neither for nor against testimony about the lack of services for children, including serious medical needs. So that's the children and youth with serious healthcare needs, which we heard a lot about in Blue Ribbon Commission, didn't we? And also you heard about the EPSDT position being reassigned and the sort of request that a new department needs to be more than a letterhead change. So this bill was carried over from last year. So obviously the dates would need to be changed. But as I said, when you did this bill last time, the timeline is quite ambitious. The current dates in the bill, and you can just sort of forward them by one in your head. A3 has an effective date for the new department of July 1st of 2026. And in the transition sections, a report from the Commissioner with recommendations on the establishment and implementation of the department would be required by January 31st of 2026. So 6 months ahead of the department going live. The legislation to update and correct inconsistencies in the law would be required by November the 30th of 2026. And B4 requires the HHS Committee to meet at least 3 times during the interim to oversee planning, with legislation to be presented to the second regular session. Obviously, this would now be 133rd. I do want to note, for example, that Minnesota took 2 years with a transition report to the legislature, and I did attach that law so that you could see at the end of that, that's the first attachment, that you could see the fairly extensive transition language. It's on the last page, actually, or just beginning on the second to last page. And I only put that there because I feel that there may need to be some additional language around the transition and the role of the legislature and the department in moving that forward. So you had questions that I really couldn't answer. There was a request for analyses or research on outcomes for states that have restructured in similar ways. And we looked for similar types of studies last time this bill came up, and also for the Blue Ribbon Commission. However, I did find some sort of adjacent, using the word a little bit loosely, materials from Washington State. Washington State enacted its DCYF, which is Children and Youth and Families, in 2017, and included in that legislation an oversight board to oversee the transition, development, and implementation of the department. And I sent you that entire report, or rather the link to the website of the oversight board, which has 5 or 6, I forget now exactly, years of annual reports that you could look at, where they do some sort of outcomes measures, which is what I think the question is asking for. But that is a fairly new department, and it's not exactly answering your question, but it is the best that I could sort of find. I did include the executive summary as the second attachment in your packet, so that you could see what the outcome and performance indicator measures that they are using. This, however, is a year over year. So that's what I meant by adjacent. It's a year over year, in the same way that you have a lot of, you get a lot of data showing sort of year over year data. This is doing that. So it's not exactly what you're trying to get at. But it does at least give you an indication of what the outcome measures that they are using for that. And then the 2025 report itself is being restructured, I guess, because they had 5 years of data, and there are issues with, I guess, the way the oversight board does their work in terms of when the data comes in and that sort of thing. So there was a 1-pager. I sent you again, the link was on that same page, but I did include the 1-pager to sort of show you the high level takeaways that they're doing. It doesn't exactly answer your question, but it really was kind of the best that I could find in terms of departments that have recently restructured and are trying to see how they did. I also, again, the Minnesota law, I gave you the law for that just so you could see what that looks like. This is an excerpt from a much larger bill. This Minnesota law was a much bigger thing around all sorts of things related to children and families. So that was just a part of it. And luckily I was able to find a place where I could print part of it instead of the 300 pages of the whole thing. And again, there was a transition report to the legislature, which I sent you a link to along with the strategic plan, but I did not include those things. You asked for the child fatality data information, but when you asked for it, you also knew that the child welfare quarterly update was coming right up. So you did receive a presentation on that. That is posted on the website for anybody outside of here that is looking for that. And you obviously have it both posted and in your folders, and I linked it to the email that you got yesterday. And then just sort of some background information. This is obviously the same bill that you had in the 131st and a similar bill in the 130th. You asked for the Blue Ribbon Commission report. You all received that last year, so I wasn't. We don't print that many reports anymore. We just only get X number that go to the printers. So I included only the executive summary. There's 2 or 3 floating around. Sophie and I had a good look, and we could only find 2 or 3, and one of them sadly was Representative Japanese. But that full report is obviously available on the web. And then the same memo that you received before, and you also received in the Blue Ribbon Commission, if you were on the Blue Ribbon Commission, we had asked our researcher in our office to do a legislative history of DHHS organization. Now it's a legislative history. It's not the whys. I know when we were doing the Blue Ribbon Commission that Molly tried really hard to find the whys, but I believe she was 2 and all of the people were gone. And so that wasn't really something that that we could find. But it outlines the organizations and reorganizations in the last 30 years, including the most recent merger of the Department of Human Services and the Department of Behavioral and Developmental Services, which also used to be called something else, which began in 2003 and took several years to complete. Nice little typo there. Not a competition. And this memo was also given to the Blue Ribbon Commission. And as I mentioned, in the first year of the Blue Ribbon Commission, because it was a 2-year study, questions were asked about what prompted changes to the department structure, but that information is no longer available. And a lot of the renaming of departments that's in that memo is around more sort of current and updated language, and removing the office names from the statute was just to give some flexibility to the department. But I do think that that Kristen's memo gives an indication of what a long process it can be. And the fiscal impact statement is not yet available from OFPR, but those of you that were here last year will remember roughly what it was last year, which was something like 4 million, I think. And I think Senator Timberlake mentioned that at the public hearing.
Thank you, Anna.
Yes, thank you very much.
Questions, comments, discussion? Representative Shigori.
Thank you, Madam Chair. I was on the Blue Ribbon Commission and we looked at this issue in great depth. And we determined that it was more important that you have the right people and the right policies in place than just how the boxes were ordered. So I will not be supporting this bill.
Thank you. Representative Graham.
Thank you, Madam Chair. No, in my time here on this committee, as Anna has pointed out, this has been brought up several times. What I've been impressed with is that the department has been listening and working to improve. And I'm now looking at the recommendations from the Blue Ribbon Commission. Almost everyone I look at, they are working on and they are reporting back to us and they are accountable but I think I'm going back to they're listening and they hear the concerns and they're trying to make a difference. Throwing the baby out with the bathwater is not the way we do things. Taking things down, hoping that everything's going to be so much better if we make something new. I don't think that makes sense. I strongly believe that the Office of Children and Family Services has worked diligently to make a difference. And this committee hears reports, they're accountable. So I agree with Representative Shigori. I will not support this bill.
Senator.
Thank you. I agree with Representative Graham and Shigori and what's been said. And I too served on the Blue Ribbon Commission, and we spent a lot of time talking about this because that was our priority. Do we need to do this? Is this something that needs to be done? Is this going to solve the problem? The loss of one child is horrible. And we all realize that and we all understand that. But we also see the work that is being done by the department. And I think simply creating another department doesn't fix the problem, nor does it save a child, unfortunately. That's why we've got to really put our efforts into making sure we are doing the right thing with the current situation that we have. So I find it that I'm not going to be able to support the bill. I do appreciate Senator Timberlake from bringing it forward again, his persistence. I also really appreciate the Honorable Bill Diamond and all of his hard work. And I really support that. And I really work hard to make sure and hold the department to the fire, to make sure that they are doing what they need to be doing to take care of our children. So I just wanted to express that.
Any other comments? Yes, Representative.
Thank you. I have always been a no vote. I spoke on the House floor no last time, and the reason I'm a no is because not for the same reasons everybody else here. I think there's a huge problem, and I still think it's management. So I'm not in favor of the bill as written, because as I said before, if you take a trash bag that's smelly from your house and put it in your shed, you've just moved smelly trash to the shed. But I'm going to vote yes, only to give the sponsor an opportunity to make the changes. And if the sponsor can amend this to satisfy the two things I need, one is a strategic, structured transition plan, which I haven't seen. And I'm not sure they're going to come up with, but I'll give them a chance. But more importantly is I have to have in writing in this bill that when we pull the Child and Family Services out of DHHS, there is an all-new leadership team, meaning nobody currently employed by DHHS or has been employed in the last 7 years from DHHS. If they can come up with that guarantee, then we can talk. So I'm going to give them a chance. If that doesn't come through, then I'll continue to be a no. Thank you.
Okay. Yes, Representative.
Thank you, Madam Chair. I really appreciate the intent of this bill and the concerns that were brought forward and the testimony delivered to us. But I think my gravest concern is that there would actually be unintended adverse effects for children if we silo this new department and we add a layer of bureaucracy. I think that we need to be doing as much as we can to strengthen DHHS right now, especially given the federal landscape and the cuts coming down and the new regulations. So I'm going to be a no vote because I really think that we need to strengthen the existing capacities within the department so that children are able to access main care. Caseworkers can reach out seamlessly. They can reach out to OFI and get and access the benefits that they deserve. Thank you.
Representative Zager.
Thank you, Madam Chair. I'm not opposed in principle to splitting of entities, but I haven't seen any evidence that it would actually achieve what we all want to achieve, which is the safety for children. Anna has put in terrific work to present what is available, information from Washington State and elsewhere. There's no evidence that I can see that one way works better than another way. And because we have there would be significant disruption to changing the way that we're doing it. The net result is more harm than good. And so I'm not philosophically opposed in the future, but it would take a lot more evidence to convince me that this would actually be better for Maine's children. So with due respect to the sponsor, I'm also a no.
Thank you, Representative. Any other comments? Questions? We received a piece of testimony from our colleague, Representative Michael Brennan. And I just want to read just a bit of it because it supports my position and the position of many who care deeply about the health, welfare, and safety of Maine children. And it's just it briefly here. This bill in siloing the Department of Child and Family Services, instead of rebuilding the supportive systems that we know are necessary and have worked in the past, that once worked for Maine families, this bill would actually take our state in the opposite direction by creating artificial silos and barriers to collaboration. The overwhelming majority of children and families involved with the state's child welfare system need multi-systemic responses that cross state agencies. Isolating the system within its own department makes serving those families more difficult, less efficient, and ultimately less effective. To help Maine children and families thrive, we should be looking at ways to integrate state agencies, improve support for families, and increase collaboration across programs. And this bill does precisely the opposite. There is not a single member of this committee, and I would opine of this legislature, who does not care deeply and chiefly for the safety of Maine children and the families who are raising them. All of us do. It goes without saying, we care deeply about the way our children are living and want nothing but the best for Maine children. We have worked on this committee to find those ways, as has the department, to improve life for Maine children and their families. This, unfortunately, is simply not an effective path toward stronger families and safer children. I would be remiss if I did not mention one more time some of the numbers of children who have tragically died in this state that have been offered in support of the need for this bill. Provide information about fatalities that is simply untrue. It is misinformation. Among those numbers are the tragic deaths of children from accidents, from car accidents, from chronic terminal conditions they were born with, drownings. The death of any child is a tragedy we all share, a deep sadness. Those families who have lost those children, who are being included in numbers that also include, yes, children, a small number of children who have tragically died at the hands of their parents or caregivers, the worst possible human beings on the face of the earth. But for those parents and caregivers who have lost children to tragic accidents and illnesses, to be included in those numbers causes them even more deep harm. And I would ask anyone quoting those numbers again to please keep those families in mind. They are still grieving. They will always grieve the tragic accidental loss of a child. Please be mindful not to politicize those families and those tragic deaths. With that, I would entertain a motion.
I make the motion of ought not to pass on LD 555.
We have a motion ought not to pass. Do we have a second? Second from Representative Daigle. All in favor? All opposed? Is there a minority report?
Just,
You need to put your mic on.
I was still thinking.
Ah,
We'll just put not to pass for now. Thank you.
Thank you.
That was the motion.
I mean, ought to pass.
You could at least change the dates, Representative Lemlin.
Yes,
So that's an ought to pass as amended.
correct.
So fiscal note the fiscal note, change of dates,
Yes,
and you're not asking for the two things that.
yes, I am asking for the two things. Let's
Okay,
go
so
for
you
it.
want, the part about the leadership
Correct.
and.
And a structured
I will figure
plan.
out a way and to work with you on how to come up with a transition plan. Do you want something that looks a little bit like Minnesota, which is a requirement for a plan? It's not a plan.
Yes, that'll be fine.
Okay.
Thank you, Sophie.
Thank you.
For first body before.
There you go. Anything on our morning agenda beyond this? Okay, so we will be back at 1:00.
to own Greenland.
Good afternoon, and thank you for joining us. Welcome to the afternoon session of the January 15th meeting of the Joint Standing Committee on Health and Human Services. This afternoon, we will have a presentation on the Maine Care Program integrity and fraud process. We will be joined this afternoon by Department of Health and Human Services Commissioner Sarah Gagne-Holmes, as well as Mr. Madden, the Deputy Director of the Division of Audit, Mr. Roth from Fraud Investigation and Recovery Unit within OFI, and Mr. Logan, who oversees the Program Integrity Unit with the Office of Maine Care Services. You will see members of our committee getting up and down and going in and out. Many of us serve on other committees or are presenting bills in other committees. You may also see members eating their lunch, and we would ask that you refrain from eating your lunch in the committee room. I think I'll have the members seated here introduce themselves, and I'll start to my right with Representative Daigle.
Good afternoon, everybody. I'm Representative Lucian Daigle, and I represent House District 1, which is the northernmost part of Maine, and we're getting snow now rather than rain, which we're happy about.
And hello, my name is Sam Zager. I represent District 116, which is part of Portland.
Good afternoon. I'm Mary Ann Moore, and I represent Senate District 6, which is all of Washington County and 16 communities in eastern Hancock County as well.
Hi, I'm Michael Lemlin. I represent House District 53, Chelsea, Randolph, Pittston, and Dresden.
Good afternoon. I'm Dan Shigori, and I represent House District 55, the communities of Hollowell, Manchester, and West Gardner.
Good afternoon. My name is Julie McCabe. I represent District 93, part of Lewiston.
I'm Representative Michelle Meyer, serving Southern Maine's District 150, which is all of Elliott, where I live, parts of Kittery and South Berwick. I'm honored to serve as this committee's House Chair. We are also joined by our nonpartisan staff, Sam Seneft from the Office of Policy and Legal Analysis to my right on the desk behind the horseshoe, and our committee clerk, Sophie Dubé.
Don't forget Abby.
And I'm sorry. We are also joined by committee member Representative Griffin, who is on Zoom. Please introduce yourself, Abby.
Good afternoon. My name is Abigail Griffin. I represent House District 34, which is Glenburn, Levan, and Kenduskeag.
And we're very happy to have you back, Abby.
Thank you.
So as I mentioned, we are joined today by the Department of Health and Human Services for a discussion, a presentation on program integrity and the fraud process. The program integrity and audit units are responsible for ensuring taxpayer dollars are spent correctly. And these individuals will provide insight into the processes in place to monitor, prevent, audit, detect, and when necessary, recover any improper billing. We don't intend today to delve into any case-specific information, but we do want to understand, as the Committee of Oversight, the process in place to maximize efficient use of public funds to ensure quality care and to maintain accountability in public healthcare programs. With that, I would welcome Commissioner Gagne-Holmes.
Trying to decide if I need my glasses. Good afternoon, Representative Meyer and members of the Joint Standing Committee for Health and Human Services. Before I begin my opening remarks, I want to take a moment to wish you all a very happy new year and to express my sincere condolences for the loss of your colleague. Representative Javner, her dedication, her steadfast dedication to the people of Maine, despite her battle against breast cancer, is inspirational, not only to me, but I dare say to many. And so I just wanted to start by acknowledging her service. Thank you for the opportunity to be before you today to share information and insight into how the department ensures accountability for the expenditures of taxpayer dollars. We are here today because DHHS takes its responsibility to safeguard public resources seriously. I am joined by the department's 3 deputy commissioners, along with our subject matter experts. While I am unable to remain for the full hearing, I wanted to begin by underscoring the importance that the department places on program compliance and integrity. This afternoon, you will hear from 3 units within the department that play a central role in identifying and responding to issues that may rise to the level of a credible allegation of fraud. While this is not the full extent of the department's oversight and internal controls, these units represent our primary mechanisms for this work. The DHHS Division of Audit, which sits in the Commissioner's office and supports the entire department, manages compliance reviews of expenditures across contracts and main care, including cost-settled payments. The Fraud Investigation and Recovery Unit within the Office for Family Independence, which investigates and acts primarily on allegations and instances of fraud by recipients of benefits. And the Main Care Program Integrity Unit within the Office of Main Care Services, which manages surveillance, review, and when appropriate, referrals to the Healthcare Crimes Unit at the Office of the Attorney General, the state's Medicaid Fraud Control Unit, which happens when program reviews identify noncompliance that meets the legal threshold of a credible allegation of fraud. It is our hope that the committee finds today's presentation helpful in illustrating the processes staff follow to identify and address fraud, overpayments, and when appropriate, to refer matters to the Office of the Attorney General or appropriate law enforcement agencies. Before we begin, I would like to offer a brief overview of the department's approach and why this work is so important. The Maine Department of Health and Human Services provides essential health and social services to Maine residents while safeguarding the public resources entrusted to our care. Every dollar we manage represents a commitment to ensure funds are used lawfully, effectively, and in direct support of the programs and people they are intended to serve. Given recent public interest in the handling of fraud allegations within publicly funded programs, it is important to share information about the actions that the department takes in service to its critical role and responsibility for oversight, compliance, and accountability. Maine DHHS operates under a framework of continuous audit, claims review, and compliance monitoring grounded in state and federal law. These processes are designed to identify billing errors, detect noncompliance, address documentation gaps, and ensure public funds are used appropriately. When issues are identified, the department acts through mandatory corrective action plans, recovery of overpayments, or referrals to appropriate law enforcement entities. When we encounter credible allegations of fraud, the department is required by law to refer those matters to the Office of the Attorney General or appropriate law enforcement agencies. This division of responsibility is intentional. DHHS administers and oversees programs and ensures compliance. Law enforcement investigates potential criminal wrongdoing. The separation protects due process, preserves investigative integrity, and ensures accountability is pursued through the proper channels. State and federal law also require the department to take specific actions when a credible allegation of fraud is identified. Under federal regulation, under Maine law, and Maine regulation, the department must impose a payment suspension unless good cause, and that's in quotes, criteria are met to delay that action. Those exceptions are narrow and purposeful, such as when law enforcement requests a delay to avoid compromising an active investigation, or when patient access to essential services could be harmed. Taken together, this means that the department's work in this area is not driven by discretion or informal judgment. It is grounded in statutory requirements, documented processes, independent review, and external enforcement. The department's role is to identify, document, act, and refer. Law enforcement role is to investigate and prosecute. The court's role is to determine culpability. Each function is distinct by design, and each is essential to accountability. The structure is intended to protect taxpayers, preserve program integrity, and ensure misuse of public funds is addressed, while also safeguarding due process and access to essential services for the people of Maine. Let me be clear. The department takes allegations of fraud very seriously. Our unwavering commitment is reflected in rigorous oversight, transparency, and coordination with law enforcement and providers to ensure these systems remain worthy of public trust. As we have recently experienced, public awareness of fraud typically follows the identification of concerns and the initiation of formal enforcement, which is evidence that these oversight systems are functioning as intended. Ultimately, trust is not built through rhetoric. It is built through consistent, lawful, and disciplined action. That is the standard we hold ourselves to at the department, and it is the standard that the people of Maine deserve. Thank you again for the opportunity to walk the committee through the department's compliance and accountability processes. I now invite Tony Madden to please come forward. Thank you.
Thank you.
Thank you.
Representative Meyer, committee members, my name is Tony Madden. I'm the Deputy Director within the DHHS Division of Audit. And I want to thank you for the opportunity to speak with you today for a few moments about some of the roles and responsibilities of DHHS Division of Audit. The Division of Audit performs compliance and cost settlement audits on approximately 600 different provider organizations and/or community agencies that receive over $1.5 billion of state and federal funds, either through the Maine Care program or from contracted services. There are two distinct units within the Division of Audit. The first being the Social Service Audit Unit, and they audit community agencies that have contracted with the department for social services. And then the Maine Care Audit Unit, which audits providers with cost-settled Maine Care programs. Some of the key activities of the Social Service Audit Unit are performing financial audits, which we also call closeout of DHHS subawards. The department contracts for a lot of services. The Social Service Unit only audits those that are classified as subawards. This is not a programmatic compliance audit. We're not testing for eligibility or to ensure that the services are provided. It's strictly a financial audit. We also ensure that subrecipients expending $1 million or more of federal awards have met the audit requirements of 2 CFR Part 200, which is more commonly referred to as the Uniform Guidance. We issue management decisions for findings pertaining to department awards. And we follow up with these subrecipients to make sure they're taking timely and appropriate corrective action on those findings. And finally, we considered taking an enforcement action on non-compliant subrecipients.
Yes, go
Thank
ahead,
you.
Senator.
Thank you for being here, Tony. My only question is, can you describe what a subaward is?
Sure. So there are two classifications when the department contracts for services. It would either be a contractor relationship or a subaward or a subrecipient relationship. Now, contractor relationships are typically for services such as IT or accounting. And then a subrecipient would be performing part of a program.
Providing that service. Okay.
Yep.
Thank you.
Yes, Representative Shigori.
Thank you, Madam Chair, and thank you for coming today. You just said that you were only concerned with financial things, not ensuring the services are actually provided. How is, that would seem to be sort of part of it. If they're not providing the services, that would be improper billing as well, right?
Well, that would not be part of our roles and responsibility within the Division of Audit. That would be more of a programmatic audit. And program offices ensure that those things are being provided. So the authority for the social service audits that we perform are really two main rules, not the state main rules, but the first being the 2 CFR Part 200, which is also known as Uniform Guidance. This is formally known as the Single Audit Act. And then the main Uniform Accounting and Auditing Practices for Community Agencies, which we refer to as MAP. And that's Title 5, Chapter 148C. When subrecipients are non-compliant, we consider taking enforcement actions. And really, there are two main actions that we take. First being suspending contract payments until providers come into compliance, or recalling all of the funding from the department until they come into compliance. And these types of actions only occur after lots and lots of communication with these subrecipients. We send reminder letters of the obligations of these providers throughout the year. If they are not complying, then we will communicate with them frequently before any action is considered. We also collaborate with program offices prior to any of the enforcement actions, because if there's financial noncompliance, there could certainly be programmatic noncompliance as well. If fraud is suspected, Division of Audit's process is to refer the provider to the appropriate authority. The three authorities being DHHS Program Integrity Unit, the Office of the Inspector General, and the Office of the Attorney General. Now, since the Social Service Unit does not audit main care dollars, it's not often that we refer to the Program Integrity Unit. Typically, it's either the Office of Inspector General if there's a significant amount of federal funding, or the Office of the Attorney General. Switching over to the main care unit, they also perform annual financial audits of cost-settled main care providers. Those providers include hospitals, nursing facilities, intermediate care facility for individuals with intellectual disabilities, residential care facilities, Appendix C, which are medical and remedial services, and private non-medical institutions, Appendix E, community residences for persons with mental illness. The main care unit also validate that provider costs are accurate and in compliance with the regulations. And again, this is not a programmatic compliance audit either.
Yes, Senator.
That brings up a question. When we talk about the cost settled providers, your audit and the portion of that, is that how they're based on their payments that they get?
Yes, so on the main care side, there are typically either a fee-for-service program or a cost-settled program.
Correct.
Fee-for-service, the provider is paid a rate, a predetermined rate for a unit of service, and then cost-settled providers are paid prospectively, and then we actually true up to actual costs at the end.
At the
with an
end
audit.
after that,
Yeah.
okay, gotcha. But the audit is a very important part of it.
Yes,
Thank you.
thank you. And the authority for the main care audits are 42 CFR Chapter 4, which is CMS, Centers for Medicare and Medicaid Services. These are the rules and regulations for the Medicare and Medicaid programs. the CMS Provider Reimbursement Manual, and then finally the Main Care Benefits Manual, which is 10-144, Chapter 101. And when cost settled main care providers are non-compliant, the Division of Audit may suspend the main care payments until the provider files an acceptable cost report, including supporting documentation. And then when payments resume, a 90% deficiency rate is applied for the time period of the suspension. Could also recall all of the funding until a provider is compliant. We could deem costs for unsupported documentation as unallowable during the audit. And again, the same thing with on the social service side, these only occur after many communications with providers.
Could you explain a little bit more? You're saying when payments resume, a 90% deficiency rate is applied. What exactly does that mean?
So during the period of the suspension, we would take a 10% of the provider's costs and deem those unallowable for that time period of the suspension.
Thank you.
And then if fraud is suspected in the main care side, divisional audits process is to refer the provider to the appropriate authority. DHHS Program Integrity Unit, the Healthcare Crimes Unit, the Attorney General's Office, and the Office of Inspector General. Are there any questions that I could answer?
There may be, yes, Representative Shigori.
Again, thank you. What's the threshold for determining what is just either, sloppy or badly done record keeping and billing and actual fraud, like they're intending to do this? How do you determine that?
That's a great question. And obviously on a case-by-case basis, if you can find intentional acts of trying to classify expenses in a certain way or things of that nature.
And also patterns, I would assume as well, right? If there's a
Certainly.
continuing
Patterns, yes. Yeah.
Okay, thank you.
Representative Zager, then Senator Moore.
Thank you, Madam Chair. Appreciate it, Director. Do you feel like you have the personnel and resources needed to carry out what the statutes federally and state require?
I think we could probably use some more bodies as I'm sure lots of organizations could in these times. I think we're doing the best we can with the personnel that we have. It's been a difficult hiring process to maintain the amount of qualified people that we have in the office.
Thank you.
Thank you.
Couple questions, and that brings up how many employees do you actually have, Tom?
Currently, we have 24 employees, and 22 of those are auditors working on cases.
Okay. And my other question would be do you have the numbers as to how many have actually, and in both of the units, have been referred to the integrity unit, or the Attorney General, or the other healthcare, for example, healthcare crimes unit?
Yeah, I don't have an exact number that I could certainly go back
Yeah.
and get that answer for you. It's not often. I would say over the last 4 or 5 years, maybe a handful, half a dozen times.
I think it would be a good number to have, just to be knowledgeable about. Thank you.
Representative Lemelin.
Thank you. If you go into a place and all their paperwork looks great, but you sense that there's something wrong on the integrity side, are you mandated or required to report that to the program integrity unit?
On the main care unit side, there is an MOU that we have with the Office of Healthcare Crimes Unit, and it lays out and spells out exactly when you should be referring that over to that office. That's the only specific instances that I can think of off the top of my head that would require us to do that.
Would you do it anyway?
Potentially, yeah, if we feel like something isn't right or, you know, the costs aren't. You know,
Well, the
well, there
cost-
may be documentation of them, but, you know, we feel something's inappropriate, certainly.
Okay, thank you.
Senator Nangle, do you want to introduce yourself and ask your
Yep.
question?
Hi, I'm Senator Nangle, Tim Nangle. I represent Senate District 26, Wyndham, Raymond, Casco, Fry Island, and parts of Westbrook. And I have a question. You have an MOU with the Healthcare Crimes Unit. Can we see that MOU?
I don't have a copy with me, but certainly I think that's something that we could provide.
Yep. Might give us a little more clarity into what you need to see in order for it to get referred. Thanks.
So thank you for being here, by the way. By Healthcare Crimes Unit, you are referring to the Medicaid Fraud Control Unit in the OAG, in the office of the OAG.
Yep.
So a Mafuku. Can you explain to the committee the relationship between the Mafuku and the Office of the Inspector General, which is federal?
Geez, I don't think I could explain that off the top of my head. Thank you, Mo.
Yeah. Hi. I'm Molly Bogart. I'm a deputy commissioner at the department. Neither of those offices are within the Department of Health and Human Services, so we just aren't the appropriate folks to
Thank you.
to answer
I
the
appreciate
question.
it.
Yeah.
Yep, I appreciate it.
I appreciate the relevance, but not
Yep.
something we should be the ones to explain.
Representative Graham, you can introduce yourself, please.
Thank you. Thank you, Madam Chair. Yes, I'm Representative Annie Graham. I serve the people of North Yarmouth and the majority of Gray, House District 105. And I apologize for being late. And thank you for being here. My question is, have you seen over the last 2 years, let's say, an increase incident of main care fraud?
I don't believe so.
Can you give me a sense of how many cases you may be considering, you know, over the past 2 years? Are you able to give us a sense of that?
Considering to refer to the appropriate authorities. On the social service side, there may be one instance of that. And on the main care unit side, I would, again, maybe one or two.
And I apologize if, in your experience, I don't know how long you've been with the department, but is that typical of the past several years that you've been with the department?
So I've been with the Division of Audit for, this is my 22nd year, and that is very typical, I would say.
Some of these questions make me just want to echo what the commission, one of the things the commissioner said at the very beginning, which is that the department in most cases and on the provider side does not do criminal investigations. And so what our teams do is review spending, compliance, and other metrics and expectations and make referrals to the appropriate authority when that is the case. We also have multiple different units that work in partnership sometime and appropriately on different pathways, which is why we have 3 folks presenting meaty subjects to you today. And so, for example, the question about the program audit, that seems like a very important piece of it. And perhaps, you know, audit saying that's not part of what we do raises a flag, but that's why you're going to hear from program integrity later, which will do some of that program compliance for main care. And other offices, you know, do that within their own contract management. And so I wanted to reorient us because the ways in which we navigate these concerns are broad and they are handled in different offices for different purposes with different allegations. And so just want to bring us back to that as, you know, as you're hearing from these 3 folks, because you're not going to have the full puzzle until we get to the end. And so wanted to reinforce that.
Understood. Thank you. Yes, Representative McCabe.
Thank you, Madam Chair. Thank you for your time this afternoon, Director Roth. When you detect non-compliance, can you give us a sense of on what schedule you're sending out those reminder letters?
The reminder letters are reminder letters of their obligations for financial reporting. Those go out for every provider annually. I'm sorry, I don't remember.
Once you've detected non-compliance, you mentioned that you issue reminder letters. What is the grace that you give?
So if we've detected non-compliance, that could be through the regular course of our audit work. And we issue audit reports with findings and any question costs that there may be. And that is on an annual basis for most of these providers. If the non-compliance, it has to do with not submitting the required financial documents that we require, then that is when we follow up with these agencies and send emails, make phone calls to remind them again of their obligations. And before we take any enforcement action, we would have, multiple communications, and then we would send a 10-day letter, a notice of if we don't receive these within 10 days, we may suspend payment or recall funding. Does that
Thank
answer
you.
your question?
Yeah, those details are helpful. Appreciate it.
Yes, Representative.
Thank you. Are these mandated audits? Do you audit every single organization? Do you have to so often? And if you do, how often is that?
So I will separate the two units, the social service unit. Community agencies are required to have an independent financial audit when they expend either state or federal funding in excess of $500,000 annually. A lot of the department subrecipients do in fact spend over that amount annually. So that would be on an annual basis that we are required to review those financial statements to make sure that they're in compliance with the rules and regulations. So that is on an annual basis. On the main care unit side, if they're a cost settled program, they are required to file the cost reports on an annual basis, and we follow up with an audit on an annual basis. That answer your question?
It does. Thank you.
Seeing no other questions. Thank you.
Thank you.
So now you'll hear from Director Roth, who's the Director of the Fraud Investigation and Recovery Unit at the Office for Family Independence.
Welcome.
Thank you. Good afternoon. And thank you, Committee Chair Meyer, and members of the committee. Looking forward to telling you about what we do within the fraud unit of DHHS. My name's Tom Roth. I'm the director of the unit. I've had the position for 11 years. I took it after retiring after a 28-year law enforcement career. Tell you a little bit about the unit. We are responsible for looking at intentional misuse of programs involving individual beneficiaries of programs such as SNAP, Main Care, and TANF, and a few other ones. Again, it's by recipients that are committing the fraud. We have 15 investigators across the state. We have one administrative support person and then myself as director. Our mission statement is to protect and serve the public interest by increasing awareness, improving the detection, civil and criminal prosecution, and prevention of welfare fraud and abuse. So let's talk about what fraud is. It's a very overarching umbrella. Fraud is when, in our world, is when an individual beneficiary intentionally misuses the programs that they've applied for. Again, I said SNAP, Main Care, and TANF programs. Misuse can happen by withholding information or providing the wrong information. It can also happen by using the benefit in an impermissible way. An example of that would be trading or selling an EBT card. Those are some of the cases we look at. The investigations can be broken down maybe in basically three functions. Our quickest investigation starts at the beginning of an application. Somebody applies for benefits for the first time. They fill out an application online or they meet with a person and go over it. And that screener, that eligibility specialist, something raises a red flag to them. They're concerned. So they send that to us. It could be who's in the house. It could be there's a discrepancy about income. They search for income, and if the person says they're not working, yet income shows up, we look into that. We generally turn those around very quick because those are dependent on people getting or not getting those benefits. We have a very short turnaround time. The next thing would be the intentional program violation. That would be a civil violation, so we're not charging the person criminally. Generally, it's because there's less evidence available, but we're still going to push through and determine whether what's going on is fraud or not. If we do, that gets sent to an overpayment specialist and it could be sent for hearing. The person will be required to pay that back or could be sanctioned off the program for a period of time. These things are generally something smaller dollar value, such as a deceased person's EBT card being used or an incarcerated person's EBT card being used. We get those quite often, unfortunately. The third component, the larger component of our work, are criminal investigations. And these generally include theft, unsworn falsification. So that's when somebody makes an application and signs under penalty of perjury that their information is accurate and it's not. Forgery, they present a document, let's say false employment papers, a landlord statement that's been forged or created so they could get benefits. And these generally involve household composition, which is the person not reporting who's in their home and what their earning capacity is, or unreported income. Could be somebody working a job they're not telling us, could be somebody working under the table, so to speak. Those are the three core functions we investigate. We also serve subpoenas to get the evidence that we need. Those subpoenas are promulgated by the Attorney General's office. They're given to us for service, and that orders a bank, a school, a financial institution, a utility company to provide us the information we need. We also serve the IPV hearing notices. I spoke about the IPV cases we do. When someone is accused of an IPV violation, they have a right to a hearing. We serve those in hand when people don't accept them by mail. We also work joint law enforcement cases rather regularly when it involves our programs of concern. Kind of the numbers that we've been involved in. In the last year, 2025, we received 890 tips through a variety of resources. About 2/3 of those were internal. Primarily, those were eligibility folks looking at the cases, seeing an anomaly, reporting that to us and us looking at it. Some of those were also from the investigators themselves. And in 2025, we conducted 52 intentional program violation investigations. That's just our unit. That's not the entire department and all the intentional program violations they did. That's just what we worked on. The next slide is going to show you some of the numbers of referral, both case numbers and dollar amounts. We refer cases to the Attorney General's office in Maine. We have 2 prosecutors assigned to work on our unit solely. We refer cases to many of the district attorney's offices in Maine. And we refer cases for federal prosecution through his U.S. Attorney's office. And then again, I talked about the IPV violations that we've had. And those are the numbers for the last 2 years. Those numbers ebb and flow. The dollar amounts sometimes go up. The case numbers go up. But, generally that's representative of the work we do. Probably the most recent thing that's become a problem for folks receiving SNAP benefits is the electronic theft of their EBT benefits through the electronic theft of cards. There are criminal organizations that are unfortunately figured out how to clone the cards, how to get the data. We've had 2 recent instances of that in Maine. We're working very actively on that with our federal partners. There have been skimming devices located in grocery stores where credit card and EBT card, because the EBT card works just like a credit card. Data can be grabbed and that can be reused and the EBT accounts can be cleaned out. We're seeking technology for grants to go after that. The department is as well for other things. And most of this occurs out of state. The theft of that data occurs elsewhere. Sometimes the cards are used within the state, but a lot of times they're done online. So it doesn't even occur in Maine. We don't have jurisdiction outside of the state of Maine. So we work with federal partners when that occurs. And again, as I said, we're working with the U.S. Attorney's Office right now on both the instances of recent TANF theft that were electronic. We make it very easy to report fraud for people. You can go to the DHHS webpage. There's an online portal. It's one of the first things that comes up when you see the site. You click on that link, you report fraud. It can be anonymous. You can put your information. We have an email that we publish. That is our fraud email inbox. And we have a hotline that records information that comes in 24 hours a day. Anytime something is sent to us, we generate a response either manually or in person that we received it. We're looking into it so that people know we are taking their reports very seriously. That's kind of a real quick overview of what we do. I'd certainly like to hear any questions you have.
Senator Moore and then Nangle, and then Representative Shigori.
Thank you very much for being here, Tom. I really appreciate that.
Thank you.
On your chart that you gave us about the number of cases that are referred for prosecution,
Mhm.
I realize you all don't handle the prosecution of them. Do we know how many of them are actually prosecuted?
Yeah, certainly many. I can get data on what the Attorney General's office has prosecuted in the last couple of years. We can get that to you.
That would be great, just to have that
Yep,
data. I
yep.
think is important.
Yep.
Because it's, the numbers are good so that we can at least see
Mhm.
how many are being referred to them and how many of them are actually prosecuted would be
Yeah,
good.
and generally, when a case is referred, it's not a snapshot in time. We're not going to have a case adjudicated within this year. They take a
Right.
long time to move through the
Yeah.
courts. So data from this year would probably be cases that we've worked on a couple of years ago.
Okay, great.
But we can get that to you.
That's great. Thank you.
Good.
Thank you for being here.
Mhm.
I appreciate it. So I have quite a few, not quite a few.
You need to turn your mic on.
Yeah, that too. I thank you for being here. I have a few questions. So somebody is able to use an incarcerated person's EBD card, meaning we don't, or the jails don't report to DHHS who's in custody so
Great,
that they
great
can.
question. And yes, we have a lot of safeguards in place to prevent that. So
Okay,
we actively look at the jail lists to make sure that those people who are incarcerated are shut off from their benefits.
okay,
Okay. Sometimes when people come in with multiple cards, which they shouldn't have, the jail alerts us to that, and we look at those. But what happens in many instances, it doesn't get reported for some reason, maybe whatever the record keeping is at the jail. And it's generally a very quick, somebody might go into jail today, their card might be used very rapidly, and then
Oh,
it gets
right.
caught by the system. We still go and look at those.
Okay.
And if we can obtain the evidence, and for us, obtaining the evidence is the transaction data.
Mhm.
We go to the store, we look at the videos see who's using it. If we can identify that person, we often charge them or submit it for an intentional program violation.
okay. Follow up.
Sure.
So you said that there were 52 fraud cases in 2025.
There were 52 IPVs, intentional program violations, that we worked on.
Oh,
Just,
okay.
just our unit worked on.
Okay,
The overpayment folks work on, I don't have the number, we could get them, but a lot, much larger number than that.
much larger number.
Yeah.
Why is there such a difference between the number of violations between 2024 and 2025?
I don't know.
Okay,
I don't know. It could be
at least you're
what,
honest.
it could be what got referred to us.
Yeah.
It could be a lot of factors. Could be what got referred to us. It could be that the overpayment folks handled more this in 25 than in 24. So we were asked to work on some of them. There could be a lot of different factors.
Yeah.
These numbers do ebb and flow.
Okay. So I have a particular constituent question.
Mm-hmm.
I have a constituent who reported to me that he saw somebody use 3 different EBT cards.
Mhm.
Is that a program violation?
Not necessarily.
Okay,
You can shop for a person with their permission, with their card, if they're infirmed or something like that.
Okay.
You can shop for them. You
Okay.
could shop for 2 people. You
Yep.
could be running a home that has 3 or 4
Yep.
infirmed people in it, and you could shop for them with their permission. And those groceries have to go to those people.
right.
Those are difficult cases for us to prove.
I'm
We get
sure.
reports of this all the time.
Yeah,
They're very difficult for us to prove. We do look at them.
yep, Okay.
I don't recall the last time we charged anyone well, we have charged for trafficking. We've charged people for trafficking, having multiple cards and using them when we could prove that they were obtained unlawfully.
okay.
Yep.
Thanks. I will let him know.
You need to turn your mic off.
Thank you, Madam Chair, and thank you, Mr. Roth, for coming this afternoon. it sounds like you only deal with programs that have federal dollars attached. If it's an all-state funded program, who does that?
We do, I mentioned Maine Care, SNAP, and TANF, which are
Right.
federal dollars passed through to the state. There are some other times that we include theft amounts to include the state supplement,
Mhm.
which comes in with the food,
Right.
with the SNAP. We've done LIHEAP before, the HEAT program, when there's fraud in that program. We've worked general assistance cases, we work housing cases, and it's primarily when there's a SNAP violation and we discover that those folks are on other programs. So we do look at state dollars. WIC, we've done, well, WIC's a federal program, but we've done the WIC as well.
But only when it's tied in with a federal dollar thing, like if
It
somebody.
doesn't have to be tied in, it's when we become aware of it, but we primarily become aware of SNAP violations. That's how we learn of the Maine Care violations, that's how we learn of the TANF. The SNAP is generally through the eligibility staff that's screening these through reviews and program quality assurance checks. That's how we learn about it.
Okay, but you mentioned GA, that would also be through SNAP, you would.
Those are local, well, those are local cases. If we learn somebody's on receiving general assistance from a community, but they're on SNAP, if we feel that they've applied for that inappropriately, that's generally referred from that community to us.
Huh.
That's how we learn about those. And then we look at the SNAP side too.
Okay,
So,
thank you.
okay.
One other question that came to mind is, no, your investigations are individuals only, correct?
Recipient, benefit recipients only.
Oh, okay,
Yes.
so it's not institutions or anything.
Well, we do retail investigations of let's say a store. If a store is involved in illegal activity with the SNAP card, the EBT card,
Okay.
we would look at stores as well,
Okay,
but primarily recipient based.
based,
It starts with the recipient allegation generally.
okay,
Mhm.
thank you.
Go ahead, Representative Zager.
Thank you, Madam Chair. It's sort of a follow-on to Senator Nangel's question about the why. Curious about the year-to-year variation. Is this variance comparable to what you've seen in your 11 years? Like,
Yes.
in other words, that
Yeah. and
some
there's-
years
yeah.
are going to be high, some years are going to be not much change year to year.
Yes, when I started with the unit, we were sending an awful lot of cases to the Attorney General's office. I was new to the unit. We had a lot of new investigators that were put on at that time. And we swamped them with cases. So we met and kind of went through what would be the best case we could present and what would be the best evidence to provide. So we've kind of refined our cases, an awful lot of evidence. These are very voluminous cases. They generally take more than a year to investigate the large AG cases, not the DA cases. Those are fairly quick. But so we've probably gone down in number, but up in quality of the cases. To my knowledge, we've only had one case. Most cases plead guilty because the evidence is so insurmountable. We've only had one case that I know of in my tenure that we lost in court, and it was a jury decision that me didn't make sense, but the jury ruled in favor of the person. So generally, the cases are pled out. They're solid cases. They're very hard to defend.
Got it. Thank you.
See no other questions. Thank you for your time
Thank you.
and your work.
Thank you.
Very applicable. This now.
Welcome. You need to.
Sorry. There we go. Good afternoon, Chair Meyer, members of the committee. My name is William Logan. I am the Associate Director of Compliance in the Office of Maine Care Services. One of my duties is overseeing our Program Integrity Unit. To give you a sense of what work we do here, the responsibility for that unit is to do surveillance and referral activities related to the Medicaid program, which we all know is Maine Care. Currently has 11 full-time positions, one manager, 7 analysts, one RN position. We have a planning and research associate and an office associate to help us with paperwork. The reason we have a program integrity unit is, one, it's required by federal law. The Code of Federal Regulations requires all states and territories to have a program integrity unit. And we've obviously put that into our Maine Care Benefits Manual, which indicates that we are to safeguard the Medicaid program from fraud, waste, and abuse. Details our authority, the various grounds we have to impose sanctions or recoupments against providers. So how do we, a lot of questions we get is how do you start a case? And they can come in from a variety of initiating sources. Obviously, we receive complaints, and those complaints can come from members, people in the public, people within Maine Care, people within our sister agency who have some programmatic oversight, could be coming in from law enforcement. We also do annually schedule reviews of certain provider or service types that we want to look at. We also do perform data analytics to see if we see variances in services or things that are outliers that might lead us down something we want to look at. We also send out explanation of medical benefit letters to beneficiaries. These are similar to the letters you get when you go to the doctor and it says, hey, you went and saw your physician for this. Here's how much we paid. Here's how much you should have paid. And that way a member could, if a member says, oh, I never got that service, they're given instructions on how to call in, and we would certainly look into that. And then finally, we do have electronic visit verification. This is a system for basically utilizing home and community-based services where providers are out there, perhaps delivering in-home services that they have to log in. Those are the main ways that cases come into program integrity.
Yes, Senator.
Thank you so much for being here, Bill. Appreciate that.
Sure.
On the scheduled reviews, how often is every provider reviewed? I mean, I know you're saying annually. Does it go through the whole list of everyone?
It doesn't. Our annual is, we basically break our annual plan up into 12 different months, and each month is going to be a different thing. So one month we may decide we want to look at a certain PNMI. So we'll select.
Just randomly select?
Randomly select. We don't have a schedule where we go through each and every single provider, like in sequence.
Okay. It's the luck of the draw, right?
Right.
May or not. Yeah, exactly.
Fair enough. So in what program integrity does, one of the primary things we do is post-payment reviews of providers. These are desk reviews. And I'll get to how that process works in a little bit. Occasionally, we will go on site to collect records. Typically, we'll show up unannounced in that case, but that's if we have some concern about bad things happening with records if we just asked for them. Obviously, all our work is for the detection of fraud, waste, or abuse in the Maine Care program. As you've probably heard already today, we do make referrals to the MFUCU, the Healthcare Crimes Unit in the Office of the Attorney General, if we suspect fraud or any other type of criminal activity. We also collaborate with what's called a UPIC, a Unified Program Integrity Contractor, Centers for Medicaid and Medicare Services. Reverse those two, should be Medicare and Medicaid Services, hires these, and they work with states, and they have people who conduct audits as well. And they coordinate with us so they're not duplicating services or reviews. We impose payment suspensions when there is a credible allegation of fraud and a determination that there's no good cause not to impose that. We do process exclusions of individuals from the Maine Care program. We do the member verification of services through those EOMB letters, and those are randomly sent out. And we do make referrals to other agencies. If we see something in the records that says, oh, well, maybe Child and Family Services, or maybe Aging and Disability Services, behavioral, maybe they want to see this. So we will refer things to them or licensing or other people who may have concurrent oversight for that provider type.
Yes, Senator.
Sorry to be the one asking all the questions
It's okay.
today.
That's what we're here for.
With just 7 people, how many Maine Care providers are they that they're looking at, I guess, or that they're overseeing?
So you're asking how many Maine Care providers we have?
Well, I mean, that would fall under your realm of responsibility, for review.
So sure. It is always a number that's in flux because we always have providers coming in and out. I think we have at the pay to level, which is the provider that's billing and receiving the funds. Then those are the providers we are generally reviewing through the desk reviews.
Okay.
There are both in-state and out-of-state, roughly 5,200. Now, not all of those are actively billing. I mean, we may have an out-of-state hospital that enrolled because a member has, and we have a few of those, or some of those that aren't billing that often, you know, a dentist or other type of provider who only sees a couple main care providers.
Right.
So that is, there are a lot
I was
of
gonna say,
providers.
and only 7 people to look at it.
Well, 8, the nurse is doing those reviews too,
Okay.
but
But still, that's not very many.
sure.
Representative Graham and then Shigori.
Thank you, Madam Chair. Thank you for being here. I wondered, and you may do this later, is it to kind of give us a typical scenario, if you're able to, about a fraud, obviously not with names and nothing that's pending, but can you give us kind of a concrete example of when you would, an example of fraud, waste, or abuse? I mean, if you just could kind of give us a sense of what we're really talking about.
Sure. Do you want to sort of like a walkthrough of the process as well? Because I know that's coming up a little bit later.
So like,
Or-
this particular provider doing, just kind of
Okay.
the concrete, like me, average person on the street, understanding, what are we talking about when we say this was fraud in the
Sure.
integrity unit?
Sure. So, I mean, what I will say to start is that I think the vast majority of our recoupments are related to what we would call overpayments, or there's a sanction because they didn't meet some requirement or they didn't fully meet the requirements that are in the main care benefits manual. So they might have some sloppy documentation. They may have billed for 7 units instead of 6, and we can't tell whether that was deliberate or the proverbial fat finger, right? But if we obviously see a pattern of something like that, then that could change the analysis. I mean, the classic example of fraud would be billing for services that weren't rendered. I think, and we do have some lists in the main care benefits manual, things that could constitute fraud. I mean, the hard part is you always need that intent, which is why we refer it to the AG's office. But if we come across an instance where we find a provider that's billing main care for services that they've already billed to another primary insurance, that would be another classic example of fraud, or billing for bundled services as well as individual services at the same time. Those are just some examples.
Thank you, Madam Chair, and thank you, Mr. Logan, for coming today. So would some other examples of fraud being if the provider was passing off people as having qualifications they didn't actually have and billing at that rate and things like that? Does that happen ever?
Yes, I think if I understand correctly, basically, you're talking about these would be medically unnecessary services because the member doesn't need the underlying service.
No, not necessarily that there's maybe a provider going into someone's home or something that they say has an RN or LPN and actually doesn't, but they're billing at that level. So that they're.
I think that would certainly fall within the category of.
Does that happen? That kind of thing happen very often, that they'll bill inappropriately, shall we say, for a service?
I mean, that can generally fall in the category of upcoding. I haven't seen a lot of that, but I mean, I wouldn't want to sit here and say that we haven't seen any instances of that.
And you also, do you do largely federal programs, or do you do any of the state programs that provide like home care services or things like that?
Primarily, we are focused on the Medicaid program, although we have occasionally looked at some of our state-funded programs. They're typically so small in comparison.
But are you, I'll rephrase that a little bit. Are you primarily the office that would deal with state-funded programs as well, or is there somebody else that would primarily handle the state-funded programs?
I think those, I mean, the state-funded programs, the one I know that we've done review on primarily would be our state-funded abortion program, because that's run through the Office of Main Care Services.
Okay, but no, something like, say, the home-based care service or something like that, you don't look at that ever or anything like that?
We haven't looked at that in my time.
Okay. Okay, thank you very much.
Did you have a question?
Yeah. Thanks for being here. I won't ask you if you could use more positions because you don't have to be a psychic to know that. What is your department's budget? Like your unit's budget?
My unit's my unit's budget is within the overall main care admin budget, which
Oh, okay.
I don't have the numbers off of.
Okay.
It's large.
And then do you have a dollar figure like for 2025 or 2024 on how much you've recovered with your investigations and programs?
I can give you a pretty close estimate
Yeah.
right now. And just, I do want to caveat on these are so two things. One is, I believe our recoveries are handled through our service center. And they are usually based on past years because a lot of our providers maybe, if they get a large recoupment, they may be on a payment plan. But I think they collected just north of 1.2 million related to program integrity matters in 2025.
Okay. Great.
I think tied into your question is in 2025, program integrity issued notices of violations totaling 799,000 to a variety of providers. Those are not final numbers yet because there still is an appeals process, and those numbers tend to sometimes come down as we see additional documentation or, get additional information about the services.
Great. Thanks.
Thank you, Madam Chair. Thank you for your time this afternoon. Are you tracking whether there's more fraud in fee-for-service programs or cost-settled programs?
We don't track a distinction on that. The referrals for fraud we have are fairly low. I don't have exact numbers as I sit here, but over the years, they typically are in the roughly 3 to 5 referrals per year to the, maybe sometimes a little bit higher than that. That's what I know over the past 5 years. But I don't know that I would say that there's any real difference between the cost settled versus the fee for service, except that the majority of our program is fee for service. Thanks.
Carry on.
So these are federal definitions about fraud, waste, or abuse. Fraud is I kind of agree with what Tom previously said. It's criminal deception intended to result in financial or personal gain. It can be false representations of fact, making false statements, or concealing information, but there is an intent requirement there. Waste is thoughtful or careless expenditures or mismanagement to the financial detriment of the program, and abuse is excessive or improper usage of things, or to use something in a manner that's somewhat contrary to the intent that the program had. And I think that those last two categories is where I would categorize most of our identified overpayments. So how a provider review generally works is if we've identified a provider and opened up a case, we will request records from that provider. And that can be a large amount of records. It can be short, small. It really does depend upon what we're looking at. Then they'll supply us those records, and then an analyst will review those. They'll go through the records, and these will be member health records and oftentimes employee records as well, and basically match those up with the requirements for the service as set forth in the Main Care Benefits Manual. If everything looks copacetic, A-OK, we will send out a letter that there's no significant findings. If we do identify violations, we issue out a notice of violation. It's a standard letter that identifies what we found, the regulatory citation that they were violated, and a detailed claim spreadsheet so they can see which claims they submitted for which members, for which dates of service, and how much we're taking back on each specific instance. And in some cases, we may send out a draft version as a courtesy to a provider up front. If we think perhaps it's a large amount and we think they misunderstood what we asked them for, and they can get us some records, and we can just start off at a better spot rather than saying, you owe me $20 million when it should be $1, just because they just forgot to give us something. What are we looking for? We're looking to see if there's a lack of documentation or inadequate documentation. We're looking for services billed or not provided. So we might see a claim for today, but there's no progress note for today. That's a problem. Impossible days. Somebody billing for more than 24 hours in a day. Haven't figured out how to do that yet. Staff qualifications. A lot of our services require certain levels of either clinical expertise or certain training requirements have been made. We've talked about coding issues or upcoding. Overbilling units. Do we see a note that says they were there for 30 minutes, but they billed for 45? Is there a lack of a specific diagnosis or something that's required? Or are we just seeing something that's a pattern or an outlier that this one or two providers are spending way more than everybody else on a particular thing? Those are just general things that often come up. Our primary sanction, we have a variety of them, is recoupment. If we make a determination that we can't determine that the provider delivered a medically necessary service, as it's stated in the main care benefits manual, we're going to take back 100% of that claim. If there's a lack of a required member signature, we consider that to be pretty significant. The rules dictate a 25% requirement because we want to make sure members are agreeing to plans of care, and it's a way of verifying that the service was in fact provided. All other sort of documentation errors we start off at 20% under our current rules. Providers can give us an argument based on factors that it should be some lesser amount, but basically it's a 0 to 20% for documentation errors, and it would really depend upon the facts and circumstances of each individual case. We do have other sanctions available to us. We can require a provider to develop a corrective action plan detailing how they're going to change their processes in order to better come into compliance with our requirements. We can suspend referrals to them if they're a provider that depends upon referrals. We can impose limitations on the number of members that a provider can serve or the number of service locations it can enroll. We always can terminate a provider, and obviously we can exclude them from the Medicaid program as well.
Yes, Senator.
Almost a question comment. The portion where it said that providers' records lack a required member's signature. Nowadays we're presented that little box and we just kind of scribble it, and I guess it does that actually transfer over to the patient's records and shows up, or?
If they are using that, they would need to have a process that does record that. Obviously, I don't want to say that my signature
Mine
is
doesn't.
that legible
It's
when I
not-
do it. But,
My cursive instructor would be very, not very happy with me, so. Yeah.
right, but I mean, some providers might be using DocuSign, for example, if they want to. Others might use some other software, but we do want that capture.
Somewhere in there.
Capturing that, yeah.
Gotcha.
So to get back to credible allegations of fraud, it starts with we receive either an allegation or a complaint. In that case, we're required to conduct a preliminary investigation. So some of the sources can be, we have a fraud hotline they can call in. We could see something through claims data mining. We could see patterns, civil false claims that are being brought in the court system, law enforcement investigations. But once we have that, we're required to review the allegations and the evidence to determine whether we think that there is a credible allegation of fraud, that we have certain indicia of reliability that it is. So then we are required to suspend payments in that circumstance unless we determine there's good cause to not suspend or only suspend in part. And we follow our standard processes to do that each time.
Yes, Senator.
Do we actually have the numbers of how many calls come into the fraud hotline versus how many we actually investigate, or do we track those numbers?
We do track those. I don't have those offhand.
I'm
I
just
think we
curious
could-
on how many hotline calls we get.
So, yeah, no, there's a couple sources we can get in. Now, it is a later slide, but
Oh, I'm
there's-
sorry.
no, that's fine. There's an online form on the OMS website that you can just go in and put stuff in.
Right.
You can email a dedicated program integrity email box, and there's a fraud hotline. And
So it's a
then
combination of the three.
and then some people in the know may directly email the program integrity director or myself saying, "Hey, we got this concern."
Okay. Thank you.
So after we in making the good cause determination, obviously there are various factors that are laid out. One is law enforcement asks us not to impose a suspension because it could impede their investigation. Others include other remedies exist to protect Medicaid funds. We determine it should be removed because the providers have been able to give us information showing now there really isn't any fraud. We make a determination that member access would be jeopardized in a specific circumstance. So if you are the sole doctor in a very, very rural community, we could certainly take that into account. If law enforcement has previously accepted a referral, but now declines to certify that it's still under investigation, then we can remove it at that point. Or if we just make a determination that it's not in the best interest of the Medicaid program. But what we do whenever we believe there's a credible allegation of fraud is we make a referral to the Healthcare Crimes Unit in the Office of the Attorney General. We have an MOU with them, which I'm happy to provide. I saw that question coming. That details the process we work, and then they will review that and either accept or decline the referral. And if they accept it, then we may provide support for them ongoing in terms of their investigation. So after payment suspension has been imposed, these are temporary in nature. That doesn't necessarily mean short. They'll be continued as long as the criminal investigation goes. I think you've already heard those can sometimes be lengthy, as well as if there's a court proceeding involved. But every quarter, we get a certification from the Mafuku about any cases we've referred and whether they continue to be under investigation and that they continue to request that we not impose a payment suspension. We also do have regular scheduled meetings with attorneys in the Healthcare Crimes Unit and their investigators to go over statuses of investigations. So beyond that, provider appeals work and, oh, I'm sorry, yeah, no, we were going to the right one. Obviously, providers have appeal rights through due process in order to challenge, dispute anything that we have made a finding on. They have 60 days from receipt of either a notice of violation or payment suspension to request an informal review. That has to be in writing, has to come to me right now, and it has to specifically identify the issues that they want to be addressed, and any issues they don't raise are waived. We will assign a different program integrity staff person to conduct that review. So it's not the same person who initially did it. They'll review what we have in the case file, anything additional that may have come in. And they will issue what's known as a final informal review decision. And that can uphold, overturn, or somewhere in the middle of what happened in the notice of violation. The provider still wishes to appeal. They then have same 60 days to request an administrative hearing. Those get referred to the Division of Administrative Hearings, which then takes over the scheduling. At that point, a hearing will be held. It's similar to court, although rules of evidence aren't applying in there. But after that hearing, the hearing officer will issue a recommended decision. That recommended decision then goes to the commissioner for final decision. After that, providers, if they're still unhappy, can appeal to the court system. I don't get to do that because I'm the department. And just one thing, so there's a little nuance with a payment suspension, simply because of the severity that can impose on a provider. There is a mechanism by which they can request an expedited informal review and an expedited hearing, which the department has the ability to grant or its discretion on.
Okay. So I don't understand any issues not raised by the provider or waived.
Sure. So
Can you give me an example?
Sure. So let's say a provider says, we cite them for 3 different violations and they say, I agree with this, I'm not going to challenge this one. I'm going to challenge these other 2. And I'm going to challenge them on these various bases. Like, I think my records are sufficient. I think you're misinterpreting the rule, whatever it might be. We'll issue our decision. That becomes the agency action that we have the hearing on. They don't get to then show up at the hearing and say, oh, that 3rd one, I changed my mind. I want to challenge that now. Or I got a new reason I want to talk about for the first time at hearing. It's kind of like how it works in regular court. If you don't identify the issue or preserve the issue for appeal, the appeal court isn't going to be addressing that for you.
Okay, but that doesn't mean that the violation is just waived. If they agree with a violation, it's still considered a violation, correct?
Yes, if they agree with one of our findings that a violation occurred, yeah, it doesn't wipe it away.
Okay.
To give you an example, I've recently had a case where, I mean, ultimately we was able to resolve it. We reviewed, like, say, 100 claims, and we were down to disputing whether 13, and we found, let's say, 90 violations. I'm making the numbers up here for illustrative purposes. We were down to talking about 13 different claims, and they were agreeing with all the other ones. And that's how, it doesn't change the violation or the recoupment there. You're just narrowing the scope of what is a legitimate bone of dispute. So after a debt becomes final, which is after all appeals have exhausted, it becomes final. At which point we then we update our records. It goes to our service center, which is the DHS Financial Service Center. They collect all the overpayments and all the money that comes into DHS. And generally those are recouped in one of two ways. Either they talk to the provider, reach some sort of agreement on a payment plan, and that repayment will either be the provider sending in a check, typically every month, or the provider just withholds, they agree to withholding of some percentage of their main care payments. And that the financial people do an analysis of how much people get each week, and they try to keep it within a fairly short time frame for repayments, depending upon it's fact specific, depending on how much money, the main care money the provider's receiving, how big the recoupment is. This is how to report fraud. There's our online reporting form. Dedicated email. This is all on the OMS webpage. We have a program integrity subpage that's easily findable. And then we have our fraud hotline. These are just some factors that we try to tell folks, including some of our sister agencies, is that we like to collaborate as much as possible, but our ability to share details of reviews may be limited. And if we've made a referral to the healthcare crimes unit, we may not even be in the loop on all the details. We may only be giving very general. In some cases, it might be a little bit more involved. As you already heard, we don't do member fraud. If something came in about member fraud, we would send that over to Tom's unit. What are we looking at? The requirements in the main care provider agreement and the main care benefits manual. And those are fairly spelled out for each specific service. We don't do licensing reviews. However, there may be some incorporation of licensing requirements, but obviously if we saw something that was of concern for licensing, we would refer over to them. We have a standing meeting with all of the sister agencies in DHHS to discuss providers who we might have a problem with, or that we might want another agency, or they might want us to have some information on or be on the lookout for. Last thing we tell people as patients that it takes a while. I mean, you will see that we may be looking at records, let's say from 2021. We didn't look at them in 2021. We may have looked at them at some point, probably within 5 years of that. That's typically where we're looking back in based upon our record retirement requirements. But we could have started that review in 2023. Then we have to ask for the records. We're going to wait for the records to come in. Then we have to review the records. And depending upon the size of the review, it could be thousands of pages of medical records that someone has to go through. Could be smaller, depends upon what we're looking at. So those take time. And then I think I've walked through the process of appeals, that it can take time for those to finally come to an endpoint, depending upon whether a provider is agreeing or choosing to appeal all the way up.
Go ahead.
Just a process question. Is the provider required to provide those records within a certain number of days?
I believe our typical request will be either 15 or 30 days, depending upon the amount we're asking for. It's not unusual for a provider to request an extension. Like, can I get another 30 days? It's a bad time for me. Someone's on vacation, you know, my record person's on vacation. And we'll generally grant that. I think I've only denied one where somebody asked for 6 months and I said no. I'll give you 30 days. But yeah, and sometimes you'll have someone who doesn't understand that we have the right to request the records, and you just have to correct them that, no, I can't have those and you have to give them to me.
Senator, and then Representative Graham.
When we're talking about like our program integrity, would that include even like checking on enrollments in daycare centers? You know, when they're getting funding or subsidy funding, would that fall under your unit, or who would be?
A daycare center would not, because daycare is not funded by main care.
Not by main
So
care.
we wouldn't look at that.
And it's a federal funded subsidy, so it would be different.
Correct. I mean, there are instances where a main care provider may be getting funds for other programs through, for example, the Department of Education, because they're serving a non-main care population. Similar to that, we'd be looking at the main care component on that.
It's just the main care part of it. Thank you.
Thank you for being here and your hard work. You know, my question is really about, you know, over the past couple of years, are we seeing an increase or a decrease in fraud overall?
I would say our referrals have remained fairly constant, or, you know, within one or two of them. I think overpayment amounts, both either collected or identified, can vary, and it really depends. Obviously, it's going to take longer to process a large case, or then, you know, I could do a bunch of small cases where I'm only reviewing 10 records and have a bunch of small, tiny recoupments, or if I'm looking at something bigger. So that's the fluctuation point of that.
And how, you know, how many, in your experience, have been referred to the healthcare fraud unit and then subsequently to the AG's unit? How often does that happen, that we have such a significant case that has to go to that level?
You know, typically we're doing it because we think there's a credible allegation of fraud. And I would say, like I said, you know, maybe averages around 3 to 5 would be a good ballpark each year. There are some times where we will actually get information from law enforcement of investigations they're doing, where they'll ask us for information. So sometimes that's the endpoint. So we don't make the referral if law enforcement's telling us they're already looking at them.
So your experience is typically pretty much no more than 3 to 5 to get to the high level that one needs to send it on to the Attorney General's office.
Where I think where I think that there's sufficient evidence that there's an allegation of fraud that warrants further investigation. Because it is a hard one. It's because you need something that's going to demonstrate intent.
Yes, Representative.
Thank you. When somebody makes a referral to you, the suggestion of, or the suspicion of fraud, that's all anonymous, right?
It can be, but sometimes people will give us their name.
And if they do, are there whistleblower protections if it's somebody from inside an organization or anything, or?
You know, I would think that they would likely fall within that. To me, it's a legal question for the agency. You know, while I am a lawyer, I don't want to necessarily give a legal opinion on it, but I think likely there are whistleblower protection laws that could apply.
Okay, thank you.
Seeing no other questions, we appreciate your time here today and your work.
Certainly, thank you.
Deputy Commissioner? Any final thoughts?
I actually, I appreciate that, had let you know. There were two things I just wanted to add on to what Bill had shared, and actually Representative Graham's question, and that conversation really got to it. One is just to be clear, you know, if there's one thing I really want you to take away from today, it is the difference between fraud and violation in program integrity. And I think, you know, there are 3 to 5 referrals to the healthcare crimes unit on average. There are many, many more violations that we work through with providers. And so to be a fraud referral, that has to reach that sort of criminal and intentional wrongdoing threshold that Bill shared the definition of. And so wanted to make sure I reinforce that. That doesn't mean there are only 3 to 5 issues that we come across in main care billing and payments over the year. And so appreciate that. And then just wanted to get back to Representative Shigori's question on state funded service. I think Bill probably heard that from his main care seat as state funded Medicaid services. But I think maybe you were talking about like the Office for Aging and Disability Services, like home care and main care lookalike services for people who may not be eligible. And those that and childcare, as Senator Moore referenced, would be programs that are managed, audited, and reviewed for compliance within the program offices. So it's not that it doesn't happen, but that would be done by Office of Aging and Disability Services. And similarly, our children's licensing and child care affordability program team would do that compliance and that enrollment work, for example, to make sure that really the kids are there is part of that licensing survey work and ongoing compliance that happens there. And I'm happy to get you more information about both of those, but just wanted to reinforce that work happens just outside of main care program integrity.
Yes, go ahead.
So on average, through the Division of Audit, the Fraud Investigation and Recovery Unit, all 3 reports that came today, how many cases get referred to the AG's office?
I would want to go
an
back
estimate.
and tally. I heard 3 to 5 from Bill. I think I heard a similar note from Tony. But I can also, our team can work on tallying all referrals to the Healthcare Crimes Unit, because, for example, every adult protective investigation, every referral for adult protective, unless it's self-neglect, is referred to the Healthcare Crimes Unit. And so there are many avenues through which we report activity that we have concerns about to healthcare crimes, and work with them to make sure it's appropriate, as Director Roth sort of identified in FIRU's work. But we can get that back to you.
It's not just fraud.
Other crime.
I'm most interested in the fraud and program integrity numbers.
Yeah.
Thanks.
Any other questions from Ms. Bogart? Seeing none, thank you so much for being here today.
Thank you.
So this committee's heard quite a bit today about the Healthcare Crimes Unit. I mentioned MFUCU, or the Medicaid Fraud Control Unit, which is in the Office of the Attorney General. There are MFUCUs in all 50 states, and they fall under the Federal Office of the Inspector General. And to understand more about how the MFUCUs work, which they are, their performance and their regulation and how they operate is detailed on the Office of the HHS Office of Inspector General website, oig.hhs.gov. This was interested taking a deep dive into how we hold providers accountable for the spending of taxpayer dollars. I kind of took a deep dive into this and really learned a lot, and I would suggest that you do that too. Anything else on our agenda today? Okay, thank you all for being here today. We really appreciate your time and your expertise and the work you're doing on behalf of Maine people. I'd entertain a motion to adjourn.
Motion to adjourn.
See you next week.